Bismillahirrahmanirrahim. Dear students, now we are going to discuss another important myeloproliferative disorders, which is chronic myeloid leukemia. As we have already discussed, there are two types of the myeloproliferative disorders. One is the classical and second is the atypical. Among the classical myeloproliferative disorders, Philadelphia chromosome positive is chronic myeloid leukemia. I am Dr Adrees Shani, working as assistant professor in Medical Unit 3, Faisalabad Medical University. Dear students, chronic myeloid leukemia, basically also known as chronic myelogenous leukemia, is a myeloproliferative disorder characterized by increased proliferation of the granulocytic cells line. Consequently, the peripheral blood cells profile shows an increased number of granulocytes and their immature precursors, including occasional blast cells. So basically, in this there is increased number of the granulocytes in the peripheral film. The incidence of the chronic myeloid leukemia is that 15% of the leukemias, out of the leukemias, 15% are chronic myeloid leukemia. Most commonly, it occurs between the age 40 to 60 years. However, any age can be affected, but commonly this age 40 to 60 years is more common in chronic myeloid leukemia. Slight male predominance is seen in patients with chronic myeloid leukemia. Dear students, one of the very important thing is Philadelphia chromosome. Philadelphia chromosome is basically present in 80% of those patients with chronic myeloid leukemia. What is Philadelphia chromosome? It is a hybrid chromosome comprising reciprocal translocation between the long arm of chromosome 9 and long arm of chromosome 22. So there is forming a fusion which is called as gene BCR ABL on chromosome 22, which has a tyrosine kinase activity. So you can, dear students, you can see this replacement of the ABL BSR from the chromosome 9 and is switched to the chromosome 22, and there is change in the chromosome 22 with BCR ABL, which has tyrosine kinase activity. So initiating factor of the chronic myeloid leukemia is still unknown. However, exposure to the ionizing radiation is very common. Increased prevalence among survivors of the atomic bombing of the Hiroshima and Nagasaki has been seen. It's more common in those patients. Radiotherapy for a cancer in the past is another risk factor for the development of the chronic myeloid leukemia. Similarly, benzene exposure is also a risk factor for CML. Dear students, CML has chronic three phases. Go through three phases. Most commonly, the patient present in the chronic phase, and some of the patient may have accelerator phase, and rare cases patient may have blast phase. You can see the, dear students, in the chronic phase there is less than 10% of the blast cells on the peripheral film. In the accelerator phase there is 10 to 19% of the blast cells in the film, which shows this is the accelerator phase. If the blast cells are more than 20%, then we call it as CML with blast crisis or blast phase. So all these phases can be there, but dear students, जो ज़्यादा मरीज आते हैं हमारे पास आउटडोर में, they are in the chronic phase. So basically it's a mature cell proliferation, and in chronic phase this patient with CML respond very well and usually easily treated and easily controlled. Remember again, the blast cells are usually less than 10% in chronic phase. In the accelerated phase, additional cytogenetic abnormalities occurs. Ultimately, the disease control becomes more difficult in the accelerated phase. As we have already discussed, dear students, the accelerated phase, the blast cells are 10 to 19% of the patients. There are blast cells. So the third phase is blast phase. In the blast phase, immature cell rapidly proliferates. So the disease transforms from the chronic to the acute leukemia, which is relatively not responding to the treatment. So dear students, if the patient present in the blast phase, it's difficult to treat the patient. However, treatment is available but it is difficult to treat the patient in blast phase. So what is the natural course of the disease or the progression of the disease is that the majority of the cases patients present in the benign phase, and this benign phase is basically a chronic phase. This lasts for almost 3 to 5 years. After 3 to 5 years, these patients go into either accelerator phase or in the blast crisis, and ultimately these patient expires. So in chronic phase, the patient is usually continue and easily controlled with the medications. Approximately 85%. So dear students, very high figure. 85% of the patients are diagnosed in chronic phase, and then they progress to the accelerator and blast phase in after 3 to 5 years of the diagnosis. So diagnosis of the CML is based on the histopathological findings in the peripheral blood and the Philadelphia chromosome in the bone marrow cells. So if the Philadelphia chromosome in bone marrow cells is positive and specific histopathological finding in peripheral blood, then the diagnosis of CML can be made. So you can see, so this is multiple cells having immature granulocytes with some blood cells. This is the chronic phase of the chronic myeloid leukemia. So dear students, there is leukocytosis with neutrophilia, bone marrow cells show blast cells. So patient, the symptom of the patient, the night sweats, the fatigue and fever without evidence of the infection is one of the classical presentation of the chronic myeloid leukemia. Sometimes patients have dragging sensation because of the massive sphenomegaly in the abdomen. तो कई दफ़ा पेशेंट कहता है कि मेरे पेट में कुछ चीज़, बहुत बड़ी चीज़ हिल रही है और थोड़ा सा पेट में खिंचाव है, ये भी पेशेंट की प्रेजेंटेशन हो सकती है. और जनरलाइज फटीग, जनरलाइज वीकनेस एंड फीवर विदाउट एविडेंस ऑफ इन्फेक्शन इज वन ऑफ द प्रेजेंटेशन ऑफ द क्रोनिक माइल्ड ल्यूकीमिया. सो क्लिनिकल पिक्चर में जैसे स्टूडेंट्स हमने अभी डिस्कस किया, लो ग्रेड फीवर, एक्सेसिव स्वेटिंग, फटीग, weight loss, loss of energy, decreased exercise tolerance, left upper quadrant, abdominal pain described as dragging and gripping sensation can be the presentation of the chronic myeloid leukemia. In some patients who present in the accelerator or acute leukemia phase of the disease, skipping the chronic phase, bleeding, fatigue, ecchymosis may be the predominant symptom of the patient. Bone pains and fever as well as increase in the bone marrow fibrosis can be the presentation of the chronic myeloid leukemia, and there may be features of the gout with polyarthritis or oligoarthritis because of the high uric acid level may also be seen. What are the investigation in patient with CML? First we go with the CBC with peripheral film, and we take the peripheral blood smear. We go with the bone marrow analysis and go with the ultrasound for liver and splenomegaly as well. What are the findings on WBCs? Usually the WBCs are markedly high, more than 1 lakh, with whole spectrum of the myeloid series. Neutrophils are raised, myelocytes are seen, metamyelocytes are seen, basophils, eosinophils are also increased. Dear students, HB may be in decrease or sometimes it may be normal. So platelet count may be variable, sometimes it is normal or may be high, or sometimes if it is blast crisis or it's the accelerated phase, the platelet may be decreased as well. If you go with the uric acid level, it is usually high. Similarly, the B12 level is very high. So you can see the large number of the myelocytes and the metamyelocytes seen in the peripheral film of the patients, with blast cells seen in the chronic phase. So bone marrow is usually hypercellular, or bone marrow cells may show Philadelphia chromosome on the cytogenic analysis of the blood or bone marrow cells. So dear students, the treatment of the chronic myeloid leukemia includes in the chronic phase usually the hydroxyurea or the interferon along with the allopurinol is usually given. So many of these patients respond very well to the hydroxyurea interferon along with the allopurinol. Nowadays, the specific treatment, the latest treatment, imatinib and asatinib, specific tyrosine kinase inhibitors, act as an inhibitor of the BCL-ABL. So these are the latest treatment. It has got changed the prognosis of the patient. The patient response is very good on patient with imatinib and asatinib. Nowadays, more commonly imatinib and asatinib, if the patient is falling or there is some support from the government, that these are the drug of choice, imatinib and asatinib, for the treatment of the chronic myeloid leukemia. In some patients who do not respond to the imatinib and asatinib, stem cell transplantation is another option with allogenic transplant or maybe autogenic transplant. However, dear student, hydroxyurea may still be used in patient intolerant of imatinib. Imatinib is our first choice for the treatment of the CML. In those patients who are resistant to the imatinib, in the blast crisis, dasatinib, another drug which can also be used in blast crisis. Dear student, the third important topic is essential thrombocythemia, which is Philadelphia chromosome negative. Dear student, usually in essential thrombocythemia, the HB is usually normal, and one of the classical finding in essential thrombocythemia is platelet count is more than 4,50,000, and usually it is more than 6 lakhs. So dear students, polycythemia rubra vera and essential thrombocythemia are almost similar. However, in polycythemia, platelet count is not usually too much high. The differentiated feature between the polycythemia and the essential thrombocythemia is HB. In polycythemia, HB may be more than 18.5 or in males and 16.5 in females. But in essential thrombocythemia, the HB is usually normal. And platelet count is usually increased in more than 6 lakhs. Dear students, ये कैसे present करते हैं? ये भी almost similar to the patient of polycythemia. Itching, erythema and warmth of hand with splenomegaly is one of the classical presentation of the essential thrombocythemia. So patient की HB ठीक हो और उसका प्लेटलेट काउंट वेरी हाई हो, स्प्लेनोमेगाली हो, तो आपने सोचना है कि इस पेशेंट को essential thrombocythemia भी हो सकता है. So dear student, this is the WHO criteria for the diagnosis of the essential thrombocythemia. The major criteria इसमें प्लेटलेट काउंट 4 लाख से 4.5 लाख से ज़्यादा हो, वो बोन मैरो बायोप्सी में मेगाकैरियोसाइट लीनिएज इंक्रीज हो, और माइनर क्राइटेरिया में क्लोनल मार्कर्स और एब्सेंट ऑफ एविडेंस ऑफ रेक्टिव थ्रोम्बोसाइटोसिस हो, तो हम इसको माइनर क्राइटेरिया में लेंगे. सो प्रेजेंस ऑफ द JAK2 म्यूटेशन with the major criteria and patient having minor criteria, we can make the diagnosis of the essential thrombocythemia. So dear student, इसके treatment भी hydroxyurea है. So polycythemia rubra vera, essential thrombocythemia and chronic myeloid leukemia, all these three are the myeloproliferative disorder we have discussed. With this, thank you very much for this listening.